Good afternoon to everyone and welcome to a new session of our GE Clinical web series dedicated this month to musculoskeletal ultrasound. I'm Frédéric Spagnoli, segment strategy leader for GE Ultrasound, and today I'm pleased to introduce to you Dr. Athina Plagou, who is consultant radiologist in Athens in Greece and also the chairperson of ESSR Ultrasound Subcommittee. She will present to you her experience in ultrasound with new technologies to assess patients with arthritis. You can use during the session the Q&A part to ask your question to Dr. Plagou, and she will answer directly at the end of the session. Now, I wish you a very good webinar, and I hand over to Dr. Plagou. Thank you and enjoy the session.
Good afternoon, everyone. Thank you, Frédéric, for the introduction. So for the next hour or so, we'll be discussing the ultrasound assessment of patients with arthritis and the impact of latest technologies. The first part of the presentation will focus on how we are supposed to scan patients in the context of arthritis, what to scan, while in the second part of the presentation, we will discuss how is ultrasound useful in assessing arthritis and how have latest technologies helped us reach easier and faster accurate diagnosis. Starting with the screening protocols in arthritis, everyone who wants to start scanning must first know how to scan. I advise you to follow the three following rules. First, you need to hold the probe with 3 fingers and make small movements with the probe. Second, be careful not to apply a lot of pressure with the probe. And finally, always use flow mode technology such as color Doppler, power Doppler imaging, or microvascular imaging. In this image, you can see how to hold the probe with 3 fingers. So we use this technique in all areas of musculoskeletal imaging, and this is quite useful. Because this way we can make small movements with the probe and be careful not to exert a lot of pressure. I'm trying to use a pointer here, but it doesn't work. Yes, okay, here it is. So as you see, we hold with 2 fingers and have the 2 fingers stabilizing our probe and usually resting on the patient's body. This is a very good technique for all areas of MSK imaging. Secondly, be careful not to apply a lot of pressure with the probe, and this is a very nice example showing you why. So if we don't apply pressure in this case of rheumatoid arthritis, you can see that the vessels appear in the inflamed synovium, while if we apply pressure, the vessels disappear, and this will not help us reach the correct diagnosis. So it is very important not to apply a lot of pressure with the probe. We use flow imaging techniques in the context of rheumatology. The 3 major techniques is color flow imaging, as you can see on the upper image, power Doppler imaging in the middle image, or microvascular imaging at the bottom. And according to the literature, flow imaging changes correlate very well with pathological changes in the synovium and soft tissues. So it is a very important diagnostic tool, and it's really helpful in reaching diagnosis in the context of rheumatology. The next question is, what do we scan when we scan a patient with arthritis? There is a recommendation from the ESSR Arthritis Subcommittee that was published a few years ago, and it describes meticulously all the screening protocols we can use to scan the different joints in the context of inflammatory joint disease. So you can use this reference article in order to study the screening protocols, and it is a free download for all ESSR members. If we want to make a shorter protocol than the ones which are recommended, and this is a question that was already asked by the audience, it was, can you share with us some tips about the investigation, time management, assessment in inflammatory arthritis? Then I suggest that you start by scanning the symptomatic joints, and be careful to always scan the joints that are frequently involved in a particular disease. So you have to be aware of the patterns of the disease. For example, in rheumatoid arthritis, we always have to scan the wrist joints, the metacarpophalangeal and peripheral interphalangeal joints. While in a patient where we suspect has osteoarthritis, we should never leave out the base of the thumb and the distal and proximal interphalangeal joints. So be aware of the patterns of the disease if you want to narrow the joints, narrow down the joints you want to scan. For this matter, we can use George Orwell's Animals Farm quote. So instead of animals, we can say joints. So all joints are equal, but some joints are more equal than others, meaning that in the context of the disease, you have to know which joints are more frequently involved and always scan those joints, which are probably more important than others. But be careful, because in most types of arthritis, the time course of disease progression is not linear. Each joint must be examined thoroughly and independently, because joint involvement is not uniform, especially in early stages. So here is the table that was published in the recommendations paper, where you can see all different joints, how we position the patient, and how we scan with our probe. This is a very useful tool in your practice, and you can have this as a guideline. For time reasons today, I will elaborate mostly on the wrist and hand joints. So we will go through together how we could have a protocol for screening these joints in a patient who is suspected to have arthritis. So what we recommend for the wrist is start with the dorsal aspect and scan first all the superficial structures such as the skin, the tendons, and the tendon sheaths, and then continue by scanning the radiocarpal, intercarpal, and radioulnar joints. So this is how we place our probe, our ultrasound probe on the wrist. We mainly scan 3 joints, start with the drudge, the distal radioulnar joint on a transverse scan, and then we move longitudinally to scan the intercarpal joints and the radiocarpal joints. So this is how we place the probe on the patient's hand. We start with a longitudinal image along the 3rd extensor tendon in the axis of the lunate and capitate, and this is the ultrasound image we get. So for those who are not very familiar with ultrasound images, I'll start explaining. So here on top, superficially, we have the skin and we have the subcutaneous tissue. This fibular structure here is the extensor tendon, and deep we can find the joint. So these hyperechoic lines represent the cortex of the bones, and in here we can look for effusion or synovitis. So this is the area of the joint we will be looking for pathology. Moving to the hand joints, we have to definitely examine the metacarpophalangeal, peripheral interphalangeal, and deep interphalangeal joints. And the longitudinal images here are the mainstay for the diagnosis. So longitudinal are much more useful than transverse images. So for the sake of time, we can confine our examination to longitudinal images alone regarding the hand joints. This is a way to scan the extensor side of the MCP joint. We see how we try to go circumferentially with our probe. You see how I hold the probe with my 3 fingers, trying to stabilize my hand and go around the joint, trying to find any signs of pathology. But first, we must be acquainted with the normal image. Here is a normal image of the MCP joint. So I'll start explaining from superficial to deep. Superficially, we have the skin, we have the subcutaneous tissue, the extensor tendon, and here this thin white line is the joint capsule. The cartilage is the dark line we can see here, and here is the area we'll be looking for pathology. But be careful, because we have a depression in the metacarpal head. This is the metacarpal neck. Be careful not to mistake this for bone erosion. Regarding the interphalangeal joints, again, we try to go circumferentially in preference with a hockey stick probe, which is easier to handle in these small joints. So we try to investigate all sides of the IP joints, the extensor, the ulnar, and especially the radial sides, which are very frequently affected by rheumatoid arthritis. Here is a normal image of our interphalangeal joint, starting from superficial to deep. I'm sure you can now recognize the skin, the subcutaneous tissue, the extensor tendon, and the joint area here. These hyperechoic straight lines represent the bone surface, and remember that below this area we get no information because sound reflects, the bone reflects the sound. So here there is no diagnostic information, all we are looking at is here. Moving to the palmar aspects of the wrist, we start with transverse joint on the area of the carpal tunnel. Here you can appreciate the flexor tendons and the median nerve. Here is the median nerve, and on top we can see the flexor retinaculum, which is a very thin line and easily recognized in high-end machines. At the bottom of the picture is the joint where we can find signs of effusion or synovitis. The MCP joints on the palmar aspect have a different appearance than the dorsal aspect we just described. So here, what we also have is the volar plate. This is hyperechoic area, which is very important to scan in the context of injury. Not so important in rheumatology, but it's nice to be able to appreciate the structure. We can look at the cartilage, which is this dark black line, and we can easily appreciate the proximal and distal recesses of the joint space. On top, this fibrillar structure are the flexor tendons. Moving more distally to the PIP joints, here we can again scan longitudinally and circumferentially around the peripheral interphalangeal joints, where we can very nicely see the volar plate here, the joint capsule, and the flexor tendons on top. While as we move more distally to the distal interphalangeal joint, we can see the joint capsule and the deep flexor tendon inserting to the distal phalanx. Now that we can appreciate normal images, we can discuss a little bit how can ultrasound be useful in assessing arthritis and how have the latest technologies help us in this area. So we have three main points where ultrasound is useful in assessing arthritis. First, and maybe the most important point, is it can help us reach an early diagnosis, which is very important in patients with arthritis. Second, it can help us follow up those patients, and last, it can help us guide our needle either for diagnostic or for therapeutic purposes. So, as we all know, early diagnosis is very crucial in rheumatology, both in rheumatoid arthritis and spondyloarthritis. Starting with rheumatoid arthritis, as you all know, pathogenesis starts from the synovium. This is the site of the pathological process, and namely the bare area. So we are looking for pathology in synovial joints and tendon sheath, and then as the disease progresses, we can find pathology in bones, tendon, capsule, and ligaments. So what will ultrasound help us find in the context of rheumatoid arthritis? First of all, we can easily find an effusion in a joint. We can find a synovitis, which is the hallmark of rheumatoid arthritis. We can look for erosions as the disease progresses. And finally, we can look at Tenosynovitis, which is again inflamed synovium, but in the sheath of the tendons. So in effusion, we know, according to the literature, that ultrasound is superior to clinical examination in the detection of effusion, even in large and easily palpable joints. Here again, we have a radiocarpal joint. I suppose you're acquainted with this image now. So here you can see this small dark area which represents a very small joint effusion. This cannot be clinically palpated or assessed. Detection of a fluid collection in joints, bursae. Sorry about this. Detection of a fluid collection in joints, bursae, tendon sheaths, and soft tissues is a useful sign of inflammation. Here we use color flow imaging to detect whether this dark area has Doppler signal, but we see that indeed it hasn't. So this is another sign that this is a fluid collection rather than inflamed synovium. Moving to synovitis, I will start by giving the OMERAD definition. So when we talk about synovitis, what do we mean? We mean hypoechogenic thickened intra-articular tissue that is non-displaceable and poorly compressible, which may or may not exhibit Doppler signal. And indeed, this is a hallmark for our RA diagnosis. So when we do find synovitis with our ultrasound scan, this is a very important finding that can document rheumatoid arthritis. Scanning the radiocarpal joint, again, you can see this dark area here, which represents inflamed synovium. We really need flow imaging techniques to see whether this is actually an active disease. But in the first image, we see that there is no activity, so there is no color flow Doppler, while in the image below, you can see these vessels which represent hyperemia and thus activity of the inflamed synovium. In cases of synovitis, it has been documented by several articles in the literature. I have just mentioned two of them. Ultrasound can detect synovitis which cannot be detected by clinical examination. Therefore, with ultrasound, we can actually reach the diagnosis even if clinical examination does not help us. But apart from that, detection of subclinical synovitis may lead to a re-evaluation of the clinical classification, placing an arthritis to oligoarticular or polyarticular, since all joints cannot be detected clinically. Here is another case of radiocarpal joint with inflamed synovium and positive Doppler signal. And at the bottom, we can see another patient with inflamed synovium. Of this hypoechoic area here is the hypertrophic synovium, and you can see this purple area, which represents microvascularity with a very sensitive flow technique called microvascular imaging. So in synovitis, ultrasound can detect it. In cases it is not detected by clinical examination, and this is the case especially when there is no soft tissue swelling. For example, here you can see a patient with a metacarpophalangeal joint. His skin is completely flat, there is no swelling, but you can see inside the joint that there is synovitis and there is increased vascularity. So indeed, this is an active synovitis. Another case here again with radiocarpal active synovitis, and this is another case where the patient was seronegative. So this is another important role of ultrasound in cases where clinically we are not sure about synovitis and laboratory tests don't give us clues. So we can easily detect seronegative patients with this scanning and this protocol. Regarding flow imaging techniques, I had a question from the audience asking, is Doppler in arthritis important, and what is each contribution? Apart from showing disease activity, which is very important, we have tried to classify synovial hyperemia because it is correlated to histological neoangiogenesis. So actually, synovitis represents disease activity, and this is something we definitely want to know. So yes, Doppler is very important and should always be used when we scan for arthritis. Apart from that, from making the diagnosis, we should further make a classification. Back in 2003, Skudlarek proposed a 4-grade classification, as you can see here, where we grade our patients and we construct our report based on this. And it is very nice if you do an ultrasound report to include the grade of your patient's activity of synovitis. For example, here we have a metacarpophalangeal joint who has a grade 1 synovitis. Grade 1 means there are only a few speckles of color Doppler in the thickened synovium. In grade 2, we find linear confluent vessels that occupy less than 50% of the surface of the thickened synovium, while in grade 3, this is indeed a very active synovitis, where more than 50% of the synovium is inflamed. Grade 0, be careful, is only used after therapy, and what it represents is that we still have synovium which is hypertrophied in grayscale, but we have no disease activity with color flow imaging, and this is a very good indicator that the disease is well managed, so the patient is in remission or is well treated. So grade 0 is only used after therapy. Elaborating a little more on flow imaging techniques, There is a new, very sensitive flow imaging technology, which is called microvascular imaging, that can detect pathology earlier. I happened to use it to a patient a few days ago, and it really helped in my diagnosis. Here you can see the metacarpophalangeal joint of a patient with pain and swelling. In grayscale, you can easily see this dark fluid collection here and all this hypertrophy of the synovium. And then we use color flow to check if there is disease activity. I wasn't really confident to call this a grade 1 because there was only one speckle of flow here. But using the microvascular imaging, I could actually find even more vessels, and I was much more confident with my diagnosis, which was actually confirmed by the rheumatologist who told me that the inflammatory laboratory tests were positive for this patient. Another example is a patient here with a swelling in the wrist. So she came, the clinician initially thought it was a ganglion because that was the only area where she had a problem. So that was either a ganglion or a monoarthritis, and this is actually a difficult diagnosis when not a lot of joints are involved. So I started by performing grayscale scanning, so I saw all this hypertrophy here. But of course, this could also be an effusion, a complicated effusion. I couldn't be sure unless I used flow imaging, and this is what I did. So I used color flow imaging, and I found positive signal. And then I used MVI, and I saw even more vessels. So I was confident enough to call this an active synovitis. Here is another case, and another important area is the tendons and the tendon sheath, because again here we have synovium. So if the tendon sheath is inflamed, this is another good evidence of disease, and some patients may be exhibiting rheumatoid arthritis only with active tenosynovitis. So be careful to always scan the tendons meticulously. Here is a transfer image of the extensor carpi-ulnar tendon in a male patient. He had a lot of pain on the ulnar side of the wrist. Clinicians know very well that extensor carpi-ulnar is a very special tendon in rheumatoid arthritis. It is very, very frequently involved. And when we find inflamed tenosynovitis in this tendon, it gives us a good evidence that this is rheumatoid arthritis. So on the transfer scan, I used color flow. You see all the blood vessels in this hypertrophied synovium. And then I used power Doppler imaging, more sensitive, see more blood vessels. And finally, macrovascular imaging, which is even more sensitive and exhibits even more blood vessels in this inflamed synovial sheath. Another important finding with ultrasound is bone erosions. And according to the OMERAD definition, bone erosion is an intra-articular discontinuity of the bone surface visible in two perpendicular planes. Here I just want to make one small comment. When we scan in ultrasound in all areas, we always scan in two perpendicular planes. So be sure that your pathology is visible in two planes. Otherwise, you cannot be confident to diagnose it. So as in all kinds of pathology, also erosions must be visible in two perpendicular planes. According to the literature, ultrasound can detect erosion much earlier than X-rays, and this is a very important thing to know. And ultrasound can detect even more erosions, 7 times more erosions than X-rays in early rheumatoid arthritis. So apart from looking for synovitis, as we can see in this metacarpophalangeal joint here, we have to check the cortical bone contour. And if we see this irregularity in the joint space, we must say that there is an erosion here. And this shows that disease has progressed even further than synovitis. Another important finding we should be looking for, we discussed this briefly in the previous case, is tenosynovitis. Again, sharing the OMERAD definition. When we talk about tenosynovitis, we mean hypoechoic or anechoic tissue, which is with or without fluid within the tendon sheath. And this again must be seen in two perpendicular planes. It may or may not exhibit Doppler signal. It can be present both in rheumatoid arthritis and peripheral spondyloarthritis. Ultrasound is the gold standard for the examination of tendons, and this was published almost 20 years ago. So, as a rule of the thumb, when you're looking for tendon pathology, use ultrasound. It's the most sensitive imaging modality. So here is another case of tenosynovitis. Again, the ECU tendon. Remember this, it's a very special tendon involved in rheumatoid arthritis. So we go on the ulnar side of the wrist and we place our probe longitudinally. And this is the image we get. This fibrillar structure here is a tendon. And on top we see hypoechoic tissue, which is thickened and exhibits MVI or color Doppler imaging as the definition of MRAC states. And if we scan this patient on the transverse view, we can also get the same information. So this is the ligament on the transverse view, and here is the hypoechoic area surrounding the tendon and the microvascularity exhibited with the MVI imaging. This is another case of tenosynovitis. This is a transverse view of the extensor digitorum tendon on the dorsal aspect of the wrist. Here we see the tendons which form the extensor digitorum communis tendon, and this hypoechoic area surrounding the tendons represents tenosynovitis. And when we use color flow imaging, we see there is increased signal, so we are confident to call this an active tenosynovitis. So moving to another big chapter in rheumatology, the spondyloarthritis. We use the McGonagall organ concept. This was introduced by McGonagall a few decades ago regarding the pathogenesis of the spondyloarthritis, and it's very important to know about this because this is how you know where you will look for pathology. So the hallmark of peripheral spondyloarthritis is enthesitis. And enthesitis is the inflammation of the bone insertion of tendons, ligaments, and joint capsules. So the enthesis organ concept helps us explain our pathologic imaging findings. So apart from enthesitis, we can look for synovitis, bursitis, and extracapsular changes to ligaments and tendon enthesis. So the ultrasound findings in peripheral spondyloarthritis are enthesitis, digital tenosynovitis, dactylitis, and synovitis. What we cannot see with ultrasound, and this is a reply to another question by the audience, which was, can ultrasound replace MRI in the assessment of patients with arthritis? I want to stress out that MRI can depict osteitis and bone marrow edema, and this is the main limitation ultrasound has. So ultrasound cannot show bone marrow edema, but this is especially important in axial spondyloarthritis. So in axial spondyloarthritis, we definitely need an MRI where we can scan the spine and the sacroiliac joints. But in peripheral spondyloarthritis, we might miss marrow edema with ultrasound, but we have all this pathology which can help us reach the diagnosis. Talking about enthesitis, again, in the literature, it has been published many years ago that ultrasound is more sensitive in the detection of enthesitis than clinical examination is. So what are we looking for with ultrasound? We are looking for a thickened enthesis, we are looking for hyperostosis, for bone erosions, enthesophytes, and bursitis. Now this is a nice example of enthesitis in an Achilles tendon of a patient with spondyloarthritis. So what we see here is the fibrillar echo structure of the Achilles tendon. And we see that the insertion or enthesis of the tendon of the calcaneus is thickened. We can also see a lot of hyperostosis here and bone erosions, and this again is a sign of enthesitis. At the bottom we can see the example of a young boy with juvenile arthritis, and here we see his Achilles tendon, which is normal, inserting to the calcaneus. This is the Achilles tendon of the other side, which is normal. But what we can see here is the retrocalcaneal bursa, which is actually swollen, while on the other side the bursa is normal and flat. Doppler signal is also very useful in enthesitis. It is proposed as an important sign of active enthesitis. So in the same patient I showed you before, if we use color flow, we can see increased vascularity in the tendon and in the bursa. You should know by now that tendons don't exhibit color flow. So in any case, if we find a positive flow signal in the tendon, it is a sign of pathology. Again, in this young boy, that the bursa was swollen and inflamed, we can see tiny vessels that are detected with microvascular imaging, but again, we don't expect to find any vessels in this area. So even these slight signs of vascularity can make us more confident about our diagnosis. As we mentioned before, another important sign of peripheral spondyloarthropathy is digital tenosynovitis. Here we have flexor tendons which are actually inflamed. We see the tendon body here, and we see this hypoechoic tissue surrounding the tendon, the flexor tendons, and showing positive flow signal. So this again is a sign of digital tenosynovitis, and if we scan on the longitudinal scan again, we can see the fibrillar echostructure of the tendon, and we can see the inflamed synovium that also exhibits a positive flow signal. Dactylitis is another important finding. It's very frequently found in the context of psoriatic arthritis. And what we are looking for is the soft tissues. So here is a finger of a patient with psoriatic arthritis. You see how much jelly we apply here on his finger, because we don't want to miss all this vascularity. So we apply a lot of gel in order to avoid applying a lot of pressure with our probe, otherwise all these vessels will not appear. So what we actually see are all these dark areas in grayscale which represent edema, and when we put color Doppler on, we see signs of vascularity which normally wouldn't be there. So this is a nice case of dactylitis in the fingers of a patient with psoriatic arthritis. So the second area where ultrasound is very useful in assessing arthritis is following up our patients. So why is it important? Because with ultrasound we can see if the patient has responded to the treatment, and we can see how his classification may have changed with the use of a specific treatment. Giving this information to the rheumatologist may help either continue his treatment or use another treatment again in case the patient has not ameliorated, or even offer an injection to one joint that is maybe persistent with the disease. So here is another example. We see the same patient we had with extensor carpi ulnaris tenosynovitis. This is when we first scanned him 3 months ago. We can see his synovium, which is enlarged. We see the increased vascularity. This was indeed a very impressive tenosynovitis, but after 3 months of treatment, you see that this classification has fallen from grade 3 to grade 1. So this is a good response to therapy, and we can continue to follow up this patient even longer to see if he actually goes to grade 0. Of course, clinical information regarding his complaints, pain or swelling are important, but this is, let's say, a kind of an objective tool, because pain is not really objective. So this is an objective tool to actually follow up our patients. Having this tool, we can find if the patient has gone into remission or relapse, and sometimes it's also a very important information for the rheumatologist, who can decide to even decrease or stop treatment if remission indeed is evident with ultrasound. Another important area where ultrasound is very useful is to guide our injections. So when we want to make a diagnosis and we are not very sure about it, we can put a needle into our joint, aspirate the fluid, and send it for a laboratory check. So in cases of diagnosis with small effusions and diagnostic problems, we can easily guide our needle in the area of synovitis or effusion. It's been mentioned in the literature that US guidance increases 3 times the rate of successful aspiration compared to conventional aspiration. Here is a case of acromioclavicular joint synovitis, and we see how our needle inserts into the area of pathology. In cases of treatment, again, it is very important to be able to guide and see our needle. We can offer an injection to patients that have 1 or 2 joints that are not responding to systematic therapy, in case the rheumatologist does not want to change the therapeutic regimen. So we can actually guide our injectate in the particular joint and be sure it goes in the right place. It is especially useful in difficult joints, and I find that rheumatologists mainly refer joints to be injected by us radiologists, especially in the area of ankle and foot. This is because there are so many vessels and so many nerves in this area, and there's no way to know how to avoid them if you can't actually see your needle with an ultrasound guidance. So in the literature, it's been mentioned that 50% of conventional joint injections are inaccurately placed, and this is actually a quite big number of inaccurately placed joints. So this is an example of performing an ankle injection under ultrasound guidance. This was a patient that was responding very well to therapy, but only his tarsal joint, this joint here, was persistent with pain, swelling, and the rheumatologist asked us to perform an ultrasound guided injection, and indeed it went very well, and the patient didn't have to change his therapeutic regimen just because of 1 persistent joint. So in conclusion, I'd like to state that new technologies in the hands of skilled technicians and radiologists can prove to be useful tools for accurate and early diagnosis in various fields of medicine, including rheumatology. And by concluding, I'd like to give special thanks to Ms. Nadia Mertica. She's a GE manager. I would like to thank her for her collaboration and significant contribution in the exploration of the new technologies and applications of advanced GE ultrasound systems.
Thank you. Thank you, Dr. Plagou, for this very good presentation. I think through your presentation, we learn how to understand clearly the role of the new technologies like high frequency imaging and the new flow modes like microvascularization into your different investigation for diagnosis, treatment, and follow-up. Now let's move to the Q&A session. You already answered to some questions that you received before the session. We have another one. So let's discover together what are the radiological features of goods on ultrasound.
Yes, okay. Gout and crystal arthropathies are also easy to scan in ultrasound. Apart from synovitis on the sides we have shown in rheumatoid arthritis, we can also find crystals. So finding crystals are quite pathognomonic. Another feature is when you scan the cartilage, you can see the double cartilage sign. For example, in the knee joint, if you scan on the transverse view, and you can see the cartilage being more echogenic, this is the double cartilage, the double contour sign of the cartilage. And in cases of chronic gout, we can find a tophi. So again, here it's important to scan the joints that are most frequently affected by gout, such as the metatarsophalangeal joints and the knee joints. And I also recommend the article I mentioned in my talk. There you can find all the different appearances of
thank you for your answer. I have another question. During your presentation, you compared a lot the color Doppler with the microvascularization on different inflammatory regions. What about the sensitivity of power Doppler compared to microvascularization or color Doppler? Do you see a big difference?
Yes, there was a case I showed. I think a power Doppler is in the middle. So color flow Doppler can show us some vascularity. Power Doppler is more sensitive than color flow, so it shows more vascularity, but it's more sensitive to movement. So we have to be more careful with our technique. And microvascular imaging is even more sensitive. So there was a case where microvascular imaging actually solved the problem because it was the only technique that really showed this microvascularization in a patient with
I have another
swollen
question for you
XT
regarding the new
So
high
this was very
frequency
helpful,
imaging.
yes.
What can you see now in addition compared to the previous probe in terms of 2D information?
Yes, well, in 2D, I've checked this probe, not only rheumatology. It was very, what I found was very interesting was in dermatology. For example, we saw small lesions and we could see ducts leading to the surface of the skin, or we found a clot in a superficial vein that was not visible with any other probe. So this was an athlete, and he had a hyperextension, and on the thorax he palpated something like a cord, and nobody could really say what it was. But with this probe, we actually found that it was a small vein, and it was indeed thrombosed. So there was a clot in this vein, and it was very nicely visible with this high-frequency probe. I find it's very easy in the workflow because it's also good in depicting deep and superficial structures. So for scanning joints,
thank you.
it's
I have
very
the last
easy
question
and quick
for you.
in our workflow.
You show a case to follow the patient where we can see the Doppler color evolution during the treatment phase. Do you use some quantification tool in addition to learn more about how the treatment evolved, or it's only color Doppler evaluation for that?
Well, actually, for classification, we use color Doppler because if there is no color Doppler, then there is no disease activity. So we actually try to quantify the color Doppler. I know that there are tools in some machines that help you in this quantification. In my practice, we don't really use it. It's like a subjective measurement,
okay.
But of course,
thank you,
it would be
Dr.
much
Plagou,
easier
for
if we had
your presentation
quantification
and your
method.
time to answer to the different questions. The webinar now is done, is over. So thank you to all the participants for your time tonight and to be there with us. I wish you a very nice evening, Dr. Plagou, and all the participants. And see you soon for the next session and the next clinical web series. Thank you and good evening.